Okay, hi. Welcome to everyone who's here, and I'm sure additional people will be joining us soon as we keep going. My name is Mitch Kamrava, a radiation oncologist at Cedars-Sinai. I'm going to be moderating today's session. Thank you to the ABS for providing this platform for us. This session is going to be on personalized skin brachytherapy, how to start 3D printing in your clinic. I'm just going to briefly present our speakers here. We have Dr. Chirag Shah from the Cleveland Clinic, who's a physician there involved with brachytherapy and was a lead author on the recent ABS skin consensus guidelines, and he'll review those with us. And then we're going to transition to two different experiences with starting 3D printing in clinic. The first will be from my institution, from Cedars-Sinai, from our two physicists involved with brachytherapy, Dr. Jennifer Steers and Dr. Tiffany Phillips. And then followed by that, we're going to have a perspective from a very, very busy skin clinic from another physicist, from Ivan Buzurovic, who will be presenting kind of the experience from the Brigham and Women's kind of clinic. So just a few more things here. Just want to bring everyone's attention to the Next Gen Brachytherapy program. You can find information about this online on the American Brachytherapy Society website. This is an effort to try to increase both mentorship and clinical exposure for kind of residents to brachytherapy. There will be kind of sites throughout the United States that are going to be able to host residents for a certain period of time to increase their exposure to all types of brachytherapy, but I think predominantly to gynecologic and GU brachytherapy. So please look at that. And also, for those of you who aren't aware, just to raise your attention to the fact that American Brachytherapy Society is on YouTube, has a YouTube channel now, where there are a number of presentations, both from these kind of webinars, sometimes from the annual meetings, that are available there for you to kind of look through and to learn about different topics kind of at your free time. The other thing is to let people know that we kind of have both a live and virtual prostate simulation workshop that will be happening kind of in August, about a month from now, August 12th to 14th, that will be taking place in Chicago. There's a really great lineup of speakers, and it's a great place to either learn or to update yourself on kind of prostate brachytherapy techniques. So I encourage everyone to look online for that program and to sign up, which should be a great program. The other thing is the ABS is also kind of putting together some different podcasts. There's a great kind of episode 2 now of Women in Brachytherapy that's featuring Patty Eiffel and our current ABS president, Dr. Ann Klopp. It's a really fun kind of podcast, so I would encourage you, if you have some time, to take a listen to that. So with that, I'm going to stop sharing my screen and going to pass it over to Dr. Chirag Shah, who will be starting off the presentation. And then for those of you that have questions, if you can just please put them in the chat, we'll kind of have a discussion at the end. Thank you, everyone.
Thank you, Dr. Kamrava, as well as the ABS, for the opportunity to speak this afternoon. And I appreciate everyone attending or listening with the tape recording for their interest in skin cancer and skin brachytherapy. As Mitch said, I'm a radiation oncologist who specializes in brachytherapy, as well as breast cancer, sarcoma, and skin cancers at the Cleveland Clinic. So as Dr. Kamrava alluded, there's a recently updated American Brachytherapy Society consensus statement for skin brachytherapy. This was a multi-institutional, multi-specialty guideline, so it includes dermatology, as well as radiation oncology, and we also had physics involved as well. So really trying to provide the complement of individuals and specialties involved with the management of skin cancer. So with regards to the guidelines, we really broke them up into patient evaluation, patient techniques, and patient selection. So with respect to patient evaluation, kind of the first and foremost thing we always think about is history and physical when thinking about which patients are appropriate for brachytherapy. So we really want to understand what are the borders of the lesion, what's the depth of the lesion, as some of the techniques may be limited by the depth they can be delivered to, as well as taking a photo for documentation and for subsequent assessment of response. We're also looking for any kind of clinical symptoms for perineural invasion, a nodal exam when appropriate, as well as looking for medical comorbidities, immunosuppression, as well as any contraindications to radiation, such as active collagen vascular disease with skin manifestations, ataxia, telangiectasia, and xeroderma pigmentosa. We often like a biopsy for histopathologic examination. One of the common questions is, what's the role of staging in the management of skin cancer? And for basal cells and early stage squamous cells, really the role of staging is limited at this time. In terms of general patient selection for brachytherapy, there's a couple of groups of patients that we consider appropriate. The first are patients who are not surgical candidates for whatever reason. The other are patients that are surgical candidates who may have comorbidities, as well as functional and cosmetic concerns, or unwilling to undergo surgery. In terms of contraindications to brachytherapy in particular, bone invasion, perineural invasion, and extension beyond the subcutaneous fat due to the inability to deliver appropriate dose without having very high superficial doses. Our group was unable to really come to a consensus regarding adjuvant brachytherapy. I think this is an area that data is evolving on, and I think we may have more clarity in the years to come. But as for it now, there is a lack of consensus on when brachytherapy should be used in the adjuvant setting. In terms of techniques, there are several brachytherapy techniques available to the clinician to deliver skin brachytherapy. The first technique is electronic brachytherapy. This is really primarily delivered with 50 to 70 kVp x-rays. The nice thing about this, minimal shielding required. The one challenge is you can't really prescribe beyond a few millimeters, because as you do, your surface dose gets hotter and hotter, and you really don't want to go too high with that. In terms of outcomes, one of the challenges with electronic brachytherapy is, while we've seen low rates of local recurrence with series, we have very limited follow-up. We also have limited follow-up as compared to traditional radiation techniques. And so prospective studies with longer follow-up are really needed to better ascertain the role of electronic brachytherapy in the management of skin cancer. And this is just a table from the consensus guidelines showing that there's a couple different electronic brachytherapy devices, including the Zoff device from Accent, the Astia from Nucleotron, the Intrabeam flat and surface applicators. And so there are different applicators, different sizes, so that the different types of lesions can be accommodated within the electronic brachytherapy applicators. In terms of patient selection for electronic brachytherapy, we really want to keep these to be small tumors under 2 centimeters in diameter and really less than 4 millimeters in depth. Otherwise, your surface dose, as noted on the previous slide, even at 3 millimeters, you're looking at anywhere from 100 to about 150 to, in some cases, even 200% of prescription when you start going to depth. You also want a regular surface. These applicators aren't really designed for curved surfaces. So you want to be able to lay the applicator flat so there's no air gaps or anything like that with the applicator. And the ABS consensus statement with respect to electronic brachytherapy for skin cancer said, consistent with the electronic brachytherapy guideline, only recommended on prospective trial and registry due to that lack of matured data, as well as comparative data with the technique. In terms of other options, radionuclide brachytherapy is a very common technique used for skin brachytherapy. It's most commonly used with iridium-192 in the United States. There's lots of different applicators. There's the Leipzig applicator, the Valencia applicator, which we both use with caps to limit surface dose. We also can use molds and flaps for non-surface dose or non-flat surfaces. And some of those commonly include the ham applicator, a catheter flap, a Freiberg flap, or as Dr. Kamrava alluded to, even 3D printed flaps. Something that we can do nowadays. And then lastly, though it's somewhat of a lost art, interstitial brachytherapy is still being used for lesions deeper than 5 millimeters. And it can be delivering very nice conformal dose distributions. In terms of radionuclide brachytherapy, excellent local control outcomes. We also have, importantly, outcomes from different clinical sites. So we sometimes worry about thin-skinned areas, or sensitive areas, but we have good data from the scalp, the nasal skin, the pinna, hands, etc. Very low rates of toxicity and good comparative data showing that this is equally efficacious as compared to, for example, Mohs surgery. In terms of patient selection for applicators, we typically like these to be similar to electronic brachytherapy, small lesions, regular surfaces, superficial, not too deep. With respect to molds and flaps, we can go up to about 5 millimeters in depth and use irregular and curved surfaces. And for interstitial, we can use for greater than 5 millimeters, though external beam radiation also recommends an appropriate option for these patients. And our ABS recommendation was for patients T1 to 2 N0 with keratinocyte carcinomas when able to meet dosimetric constraints, with the technique of these being based on location, depth, and volume. In terms of dose and fractionation from the table on the left, what you should take away is there are a lot of options depending on the brachytherapy technique. Importantly, to take away from this is when you're looking at basal cells, you really want an EQ D210 of 56 gray. And for squamous cells, you really want an EQ D210 of 65 gray or higher. And typically, in my thinking, I try to use the shortest course possible when appropriate. I do use longer fractionated courses for more sensitive areas to limit long-term toxicities to sensitive areas like the face, for example. One of the biggest challenges I get asked about skin brachytherapy is how do we define our target? And I think this is where, for example, a good physical exam and taking a photo are really important. So for example, we define the GTV as really the clinically and radiographically apparent tumor. The CTV for basal cells, and they're typically low risk, are about 5 millimeters. If you have some higher risk features, you can go up to 1 centimeter. For squames, we can go even larger, up to 2 centimeters. For larger tumors, poor differentiation. And typically our PTV is right around 5 millimeters circumferentially and 1 millimeter for depth. With these electronic brachytherapy and radionuclide applicators, we really want to limit depth to about 4 millimeters at its most. Otherwise, the surface dose gets quite high. In terms of postoperatively, we typically, if we're going to do postoperative brachytherapy, typically use the scar and around 5 to 10 millimeters around it with a PTV of 2 to 5 millimeters. In terms of molds and flaps as well as interstitial brachytherapy, with molds and flaps, it's very similar to surface applicators, but we can go to higher depths with it. With respect to interstitial brachytherapy, similarly, the GTV is the clinically and radiographically apparent tumor, a CTV expansion of 1 centimeter. And with interstitial applicators, we don't really have to worry about as much motion, so the CTV can be the PTV, and you can go beyond 5 millimeters with this technique. In conclusion, brachytherapy is a standard of care approach for appropriately selected patients with early stage keratinocyte carcinoma. Multiple techniques are available based on the clinical scenario. Radionuclide brachytherapy is well established, while electronic brachytherapy requires further data. Thank you very much.
Awesome. Thank you so much, Dr. Shah. We'll transition over to Dr. Phillips and Dr. Steers. Just one thing that I forgot to mention is that there will be SACME opportunity here credit. The link to the questions will be sent out at the end of the talk, and hopefully we're paying attention to the last talk, because really the main questions will be based off of that. And so we'll transition over now to implementing 3D printed applicators for surface brachytherapy.
Great, thank you for having us. We're going to talk a little bit about our clinical experience first, just implementing 3D printed applicators, and also what our clinical workflow looks like, and show a few examples of our first few cases. So as we talked about, surface brachy has been typically performed using commercial flat molds or handmade molds. And the design, especially if you're using a handmade mold or even a flat mold, the spacing and depth of catheters directly affects the quality of the final plan. However, these molds are limited in their ability to conform to patient surfaces, especially when you have highly curved surfaces like a nose. So when we move towards thinking about 3D printing, 3D molds offer us the opportunity for not only better fitting molds, but also more degrees of freedom to customize the mold and therefore the final dosimetry. So we can change the depth and the spacing of catheters and use this to our advantage to get great coverage and also reduce really high hotspots in plans. In the way that we do 3D molds at our clinic, we also have the ability to iterate on the mold design with the use of pre-plans. So we can kind of go back and forth between the treatment planning system and our mold software and determine, what is going to give us the best plan or close to the best plan that we can get. And as an added benefit, the time on the CT table for the patient compared to when we were using handmade molds in our clinic is at least half of what it was previously.
So when we started thinking about moving into 3D printing for our applicators, we had no experience with 3D printing and very limited knowledge. So we needed a solution that would be something that we could easily jump into. For us, we found that the Adaptiiv solution was what was going to work for us. It allows us to create brachytherapy surface applicators, a simple bolus, and even modulated electron bolus. Currently, we're focusing in our clinic on the brachytherapy surface applicators, and the Adaptiiv solution was nice for us because we could integrate it into our Eclipse workflow. The software uses the CT and structured DICOM files, and we can export from Eclipse and import into the Adaptiiv software, and then we can also export and import back into Eclipse, and this is how we can iterate to get pre and post plans to optimize our channel locations. The print material that we use currently is a Cheetah TPU filament. This is a filament that was both commissioned and tested by Adaptiiv as well as by our clinic. The build volume on our printer, we use this Axiom 20 printer, is about 12 by 12 with a 20-inch height. This has been sufficient for everything we've needed to print so far, and we've been very happy with this printer. Currently, we've done several applicators, and we've noted that our print time ranges from 6 to 17 hours, depending on the size and complexity of the applicator. And for us, the Adaptiiv software was extra attractive because it allows us to place the channel paths into the molds and then customize the location and depth from surface. Here's one of the examples of a scalp patient. In purple, you can see the wire from the CT scan, and you have some light green channel tracks here that the software allows us to put in for the applicator. These channels, while they're printed into the applicator, we do fix catheters into the channels to assure that we have a smooth path for the source to traverse. So when we started, we needed to do initial testing and commissioning. We started with vendor hardware and software training so that we could get our feet wet using the printer and learn all the little tricks in the software. We started with benchmark prints that were provided by the company, and the benchmark prints allowed us to not only check the printer setup to ensure that everything was printing accurately, but also the mold integrity. We checked dimensions for accuracy. So we have in our planning system 5mm thickness, and we can confirm that the physical thickness once printed matches. We also checked expected Hounsfield units for the filament that we were using. For our brachytherapy, this is not as crucial since we're using TG43, but for printing surface bolus for external beam, this is something that is definitely crucial for your calculation models. Moving on to some of the commissioning, we needed to develop a process so that we could identify any safety concerns or issues that we might have. We basically did an end-to-end setup testing. So we started with using a rando phantom and looking at creating a body contour in Eclipse. This is very crucial for your applicator to have a smooth and good fit. For us, this was an iterative process on the rando phantom. And on the right, you can see that by changing your window and level, you can get a very different body surface. So for us, we CT'd our rando phantom with an SRS protocol and 1.25mm slices and wanted to optimize the Hounsfield units. We did print several different applicators and checked them on CT until we found the right fit for the rando phantom. And for us, we found that using our Brain SRS protocol, our Hounsfield window that we used for optimal fit was -380 to +300. The other areas we needed to look at in commissioning are the tunnel radius and path for the applicators. As you can imagine, that the tunnel radius needs to be wide enough for the catheters. So we're using the 4.7 French catheters. And for these catheters, we tested both 1.8 millimeter radius and 2 millimeter radius of the tunnels. We found that 1.8 was just a little too snug. So we went with 2 millimeters, and now we routinely use 2 millimeters successfully. The other aspect of the channels that we need to ensure for deliverability is the radius of curvature. So if the curve of a channel path is too tight, then the wire cannot traverse and you'll get a blockage error. So the combination of these 4.7 French catheters and the afterloader that we currently use, which is the Varian Verisource, the recommended radius of curvature limit of 14 millimeters. So we set that as our threshold, and we tested both larger and smaller radii. And we did find that 14 millimeters was the limit, and anything that was smaller than that, the wire would not traverse and you'd get a blockage. So we set this in our system. Here's a quick shot of a tight curve and the wire not able to traverse it. And then when we set this 14 millimeter in the software, it will alert you with red if the curvature is too tight, and then you can adjust it so that you know when you print that you will have a successful passage of the wire. We also wanted to ensure that we set up a QA process to ensure the safety and accuracy and deliverability of the patient plans. So the first step of our process is to visually inspect the molds when they print. While we did optimize the printer settings with the benchmark print, we found that there are a few things you need to watch out for when you're printing an applicator. So for us, the first one that we found was if our filament on these larger applicators gets tangled as it's being fed into the printer, it can pull and you can get these mismatched prints. So we re-optimized how our filament is hung and fed into the printer, and that has fixed that issue. Also, we found that if you have a narrow or tall applicator, you sometimes get lifting on the corners. And for us, we went back and forth a few times, but we were able to figure out that by adding a little extra brim around the applicator, you can ensure a close contact and that the print will not lift off the bed. So we now routinely add that extra brim if we have a narrow or tall applicator. We also wanted to check mold size accuracy. So we developed bolus molds in Eclipse, as you can see in A, and then just like we did with our benchmark print, we just confirmed that what we're printing is accurate. And for each applicator, we do post-processing to ensure that everything is reproducible and safe. So we affix the 4.7 French catheters in the mold with a cold shot glue gun so that we don't damage the catheters. We want to make sure that they're in the proper channels and that the channel numbers are labeled so that there will be a smooth passage of the source in the correct channel when we treat the patient. We also make sure there's no rough edges or anything that could be uncomfortable for the patient. And we routinely use a Dremel just to sand down any areas that could be uncomfortable for the patient.
So after the mold is prepared, we then deliver a test plan that drives the source positions to the end of each channel to ensure deliverability. And there's an example picture of that shown here. We also try and put it in a similar orientation that it will be on the patient when they're treated. We actually did catch an issue with one mold by doing this, and it was a nose mold. And what happened was that it wasn't the path inside the mold, but rather the way we had glued the catheter, and it was a little bit too extreme of a bend right at the base of the mold. And so this was a really easy fix by just removing the glue, since it kind of you can snap it off with a little bit of force, and re-gluing it so it had a less extreme angle. Finally, after all this is done and we do the drive test, we bring the patient back for their fit CT, is what we call it. This is to make sure that the mold fits properly. It has minimal air gaps. So you can see an example of a nose and cheek on the right here. We also check the mold for any visible abnormalities on CT, of which we haven't really found any. And then also we take some patient-specific measurements or make any immobilization devices that we feel we need for this patient. So you can use an open face mask and kind of make paint marks where the mold should line up on the mask. Or we've also found that for a lot of patients, the mold sits really nicely and snug on, especially for noses. So you can make anatomical landmark measurements, say between the top of the mold and the eyebrows, or the bottom of the mold and their chin, for example. This final CT is what we use for the final treatment plan. So you can see our first scalp case on the right here as we slice through. The lesion is in red and the prescription isodose in yellow. And so this final CT is used for the final treatment planning, but we register everything from the pre-plan, and there's good agreement between pre-plans and post-plans. The whole workflow of this process for us actually starts when the patient comes in. We have two CT scans, and the first CT scan is a wires, no wires scan. So the wires are used to define the area being treated, and then we take the wires off and use the no wire CT to acquire and create the body surface for the mold creation step. We then edit the body contour as we talked about with our window level settings. And again, just to note that your window level matters. You can get a very different surface if you use inappropriate settings. After this step, we then make a solid bolus in our treatment planning system, which for us is Eclipse. And then this we push to the 3D bolus Adaptiiv software. And so in this software, it pulls in that bolus from Eclipse and you can start to define your catheter channels. The nice part about this is you can then push this design back to your treatment planning system and make your pre-plan. And if you don't really like the way the dosimetry is looking, then you can change the way the catheters are laying in the mold, the depth and spacing of the catheter. So you can kind of go through this process as much as you want, hopefully not too much, because it takes a lot of time to do this step. Once you're happy with your pre-plan and your mold design, we then print the physical mold. And as Tiffany talked about, we do any post-processing that we need to do for the mold. And then we do our QA and drive test. After this, we also have this little document that we created, and this goes in the patient plan document. And so just to make sure that we're documenting that, yes, we did complete all the checks and that the mold passed, and there's some sort of document that we sign that records that. And then finally, as we discussed, the patient comes back for their second CT. We handle any immobilization or setup, pictures or marks that we need at that time, and then they move on to treatment. So we just have a couple pictures of a few plans we've treated so far on the right here. You can see that there are very minimal air gaps in the regions being treated for this nose and this cheek mold. And this is the 3-site forehead scalp mold that's printing on the left here. This was one of our longest prints, but most of them are probably 6 to 10 hours on average. And we've also found that our post-plan dosimetry is always within 1% of our pre-plan dosimetry, and we think this is a testament to the great fit that we're getting for these molds, and we're really happy with the results. So thank you.
Thank you guys so much. Obviously, thank you guys for making that happen kind of here. It's been a really nice tool for us to have as something to offer for appropriate candidates for that. So we're gonna transition over to the next talk, kind of hear about different kind of workflow in a very, very busy and experienced kind of skin center over at Brigham and Women's. So we'll transition over to that. I think you're on mute still, Ivan.
Thank you, Mitch.
Perfect. Thank you so much
I'll
for
repeat
being
my
here.
introduction. Great. So, Mitch, thank you very much and ABS for organizing such a great event that will promote brachytherapy and help many institutions to think about other options in a treatment of skin brachytherapy. So what I'm going to do here, I will actually explain how we came up to the 3D printing and implementation of a 3D printing in our department. I will give 2 slides of brachytherapy division statistics to understand what is the workload and what are the treatments of brachytherapy that we do. And in one slide, I will say what is the strategic goal in skin treatments in our brachytherapy division. And after that, we will go through the current workflows and limitation. Many limitations in including different dosimetry, inaccurate dosimetry, including how to deal with the complexity in brachytherapy, where target is extremely complicated, curvy, rounded, with the complicated topologies, etc. And after that, we will come up to the 3D printouts. I will actually explain how we call print 3D treatment plan. We do not print the applicator only. We tend to say that we actually 3D print the complete treatment plan. By the way, I forgot to say that I am a chief of brachytherapy at Dana-Farber and Brigham Women's Cancer Center. In the previous years, we evolved a lot, and you can see the number of patients. We treat up to 500 patients annually, and interestingly, you can see that in the previous year that was challenging for everybody in this field. We actually didn't decrease the number of patients that we were treated. We had different strategies to achieve those things. I'm not going to talk a lot about that, but one of the strategies, obviously, to change fractionation. You can see that we deliver less fractions because we didn't want to return any patients from our institution, not to, and allowing them to be properly treated. If you look at the data structures, I will mention 2 numbers. 90% of all brachytherapy treatments of about 13 to 1500, depending on the year, of different kind of brachytherapy. 90% is HDR brachytherapy with iridium-192, so well-known afterloading technique. However, about 40% of all HDR treatments is skin brachytherapy. It's about 530 fractions on average over the course of over a period of 5 years, and 75% of them were complex. We define complex when we utilize more than 20 catheters, when you have extremely curvy or maybe extremely small target, and when you have a complicated topology. So our research goal and our clinical goals in brachytherapy, let's try to do sim and treat. Let's sim the patient and let's connect the patient to the afterloader and treat it immediately. We are working with the surface imaging, and we are working on implementation on MRI into a skin brachytherapy because we want to treat up to dermis. We want to see that there is in all task groups that we previously participated, there is a debate, what is the depth? So depth is different. Sometimes it's 3, sometimes you have a depth of the plaque locally up to 7. And what can you treat with 7 or 8? What is the surface dose when you have to stop treating or try with the brachytherapy, try alternative methodologies? So basically, we wanted to utilize MRI to see, to go to the proper depth depending on a patient. We actually, in order to simplify, the process, we actually realized that we have to have an automatic catheter digitization and automatic treatment planning somehow in order to connect sim patient, connect to afterloader and treat immediately. And of course, this is easy to say, but it is extremely hard to achieve. And this is a complex in the principal steps of skin brachytherapy with HDR sources is simulation, treatment planning, and treatment delivery. We actually realize, let's first present 2 cases to understand what a complex means for us. This is a patient diagnosed with a CTCL of a skin of the face. We actually had 44 catheters, custom-made face mask, believe it or not, with a 700 valve position, and the total treatment time for an average activity of a source of 7 curie was 37 minutes. You can see when you have to digitize the catheters or even to set up this without a properly trained team and without proper strategy, this becomes nightmare. Many institutions would say, we would give up and send these guys to Brigham. And this is a treatment plan. Yellow is 100% isodose line. And maybe this is the most beautiful isodose distribution in radiation therapy. Even if you look at the coronal, you have equidistant position of a 100 isodose line along a whole surface, or actually whole face. Let's look at the second patient. Second patient is diagnosed with the angiosarcoma of scalp. After resection, we treated a scar with a margin of 5 centimeters. So when we treat a patient with a margin of 5 centimeters, if recurrence is happening, they're happening at a centimeter 6. So you can read about that in our latest publication about survival rate of angiosarcoma patients. So this gentleman received a treatment of 51 grain total in 17 fractions, and treatment was 13 minutes. This is his simulation face mask with the immobilization aquaplast material, also treatment plan 3 millimeters under skin or less than that, not to reach the bone. We actually realize if we are able just to remove the catheter reconstruction, we can save 1 month of a physicist work, just if we can press the button and have all catheters reconstructed. So if we want to utilize 3D printing, we should be able to have a similar achievement. And I will show you here actually automatic catheter reconstruction for a patient diagnosed with CTCL on a full arm, and this is on MRI images. So during this was done in our in-house developed software, and during this 1 minute, I would actually talk about other limitation. Our clinic is complex, but we don't want our treatment planning to be more complicated by including the 3D flap applicators. We do not want to spend additional time and be concerned if our source is going to stuck inside the channel, inside the catheter of 3D printed applicator, because that is a huge safety issue. So also we know in surface brachytherapy, and you can also read in Brachytherapy journal in one of our publications, we know that we deliver 6% colder plan because we don't have backscatter. So what is happening? We cannot do with the surface, with the 3D printed applicators, very smooth transition to a clinic. There is an additional QA, and it is very likely that we cannot simplify our procedure with that. So we decided actually not to use 3D printed applicators, but this is not the end of the story. You can see actually here guiding lines of applicator, and if I go a little bit faster, just the 3 guiding lines and 1 click, and we have a digitized applicators. We have all applicators digitized in just a few seconds. So we have one piece. We can digitize the applicators. Let's see how we can generate a 3D, automatically 3D plan. And that's actually is, so what is the goal? Let's look at the workflow of a 3D treatment planning that we generated. This was actually published in our task group, APM task group 253 of a surface brachytherapy. But what would happen if we completely eliminate classical way of treatment planning? We have a catheter digitization. We know that our physicists can save 1 month in our clinic just because of this development. And we come to this. Let's flip the problem, those calculations. We have a shell where all 12 points are sitting. So let's calculate the 12 times that will give you 100% of isodose line, 8 millimeters equidistantly, or 3 millimeters for a very standard treatment, 3 millimeters in the patient's skin. So basically, with that piece of software, we realized that we can make automatic catheter digitization and we can generate automatic treatment plan. So let's see how we can implement 3D technology into that. I said that we decided not to print applicators because currently fiber flap or variant surface applicator set, the blue one, or also the MIC applicator is still pretty good to be used for a skin, no need for a special QA. And we decided to print the applicator holder as the immobilization device that we will place the applicator into. So what is the benefit of that? Benefit of that is when you scan the patient, when you put the flap applicator, and when you process the information based on the CT scan, you know the geometry of the flap applicator. When you know geometry, you exactly know the position of your catheters and position of your 12 points. The other thing, with the previously shown methodology of calculating 12 times, so the 100% isodose line is 8 millimeters away from a center of a source, having in mind that spheres in the fiber flap applicators are of radius of 5 millimeters, we actually calculated those 3 millimeters under the skin. So basically, each of our applicator holders contains another additional piece of information, and that's a digital file with 2 matrices. One matrix contains information about catheters, and the second matrix contains information about treatment time. And we interface those information to the treatment planning system, and we do not digitize, do not contour, do not have to do regular process or normalization and optimization. We just print out a treatment plan. We print out the holder, and we print out, we actually generate automatically treatment plan. So what is the additional benefit? We print out our applicator holder in a way to allow for a backscatter. So because we know that we deliver a cold plan, because of lack of backscatter, this applicator holder will solve another problem. We are solving a problem with accurate delivery of the dose. Treatment planning system, excluding model-based treatment planning system, for instance, known ACE or Accurus, will actually show this difference, and of course other measurements, and it is basically no. It is also know that we deliver a colder plan in the presence of a bone on a scalp when we treat the flank because of a presence of proximity of the lungs. We deliver up to 4% hotter plan. So we solve several problems with this, and we were able to generate different models of the applicators using this technology. And these are rendering of some of our applicator, and this is what it looks like in practice. And so we have a fiber flap, we have a printed holder, and it goes to the patient target. So immobilization is extremely reproducible, uncomplicated, and we have a fully automated plan. We practically use treatment planning system only to generate a TCS DICOM file that goes to the afterloader. We use actually our own in-house generated treatment planning system. This is what it looks like. We place the applicator in, we use it for a patient, and we can, after proper sterilization, reuse a fiber flap applicator, and the holder is printed out for each patient. So we actually tested this, and we have been using this in the clinic, and we realized that there is a significant improvement in immobilization. There is significant actually improvement in dosimetry because we avoided manual adjustment of the dose. Our local dosimetry is improved significantly, and we tested on several patients. For instance, patient with the CTCL on the forehead, with the full scalp treatment, with the forehead and the nasal area. We actually show that actually we deliver lower dose to the more homogeneous dose, lower dose to the organs at risk, thanks to the automatically generated treatment plan. So this is our option for implementation of 3D printed technology in our clinic. And in conclusion, we actually generated almost invisible treatment planning procedure. We use deep learning and artificial intelligence to learn how to achieve those plans, since it was shown that they have improved dosimetry if we compare it against the classically generated treatment plan. As I mentioned previously, mobilization is uncomplicated. We actually did some measurements about process improvement, and we show that there are significant improvements. We will be continuing using MRI on the skin, and since we have a catheter digitization, we can use MRI only treatment planning of the skin, and you will be able to read in one of the next issues of medical physics. There is no need for additional quality assurance other than standard quality assurance. And maybe the last, but not the least advantage is that all our treatment plans become unified. We remove the dexterity of a physicist and the personal skill from a treatment planning, which in a institution when multiple people do the same task can significantly improve the quality of the generated treatment plan. And I will thank you for your attention.
Thank you so much. That was amazing. That was great. I don't see any specific questions in the chat, so I'll go ahead and ask some, and we'll see if we get some. I guess my first question is for Ivan. Now that you have an extra month of free time, do you get vacation, or do they just find other things for you to do?
Of course, we take vacation. That unfortunately never happens. So that's a continuous process of improving. Basically, when management realized that, they said, "Oh, that's great. So you don't need that many physicists in your group." So basically, overall goal is try to simplify the process, to use modern technologies, and we will actually see how this new way of delivering treatment plan are going to transit to the patient outcome. We are going to measure the recurrences, and it's especially important with a highly complicated disease such as angiosarcoma that I mentioned previously. So we would actually put some quantitative measurement of this methodology, and we will know at some point in the future, was it just a technical improvement, or was it worth to did it touch properly the patients?
I'll ask one more, and then there are some questions coming in. It's also for Ivan. So you guys have changed the workflow so fundamentally from, I guess, what we've traditionally thought is, have you guys compared how this easier I guess more streamlined workflow is compared to like doing electrons for skin? Or do you feel like this is even easier and kind of faster? Or
yeah, so actually last month we have a paper, selection criteria between HDR brachytherapy and electron external beam treatment therapy. Electrons are good for flat surfaces. They're not good if you have to do large surfaces, match electron beams. They're not good when the angle of an applicator goes above 30%. So when you have a curvature, standard treatment is you cannot do electron qualitatively, and also it is hard to stop electrons at the depth of 3 millimeters, irrespective of bolus. Believe it or not, we tried with the VMAT. VMAT plan, we were able to stop the dose at 7 millimeters in some of the cases for a treatment of a scalp, and in some of the cases was acceptable, but in some of the cases really not. So there are pros and cons, but about the streamline, we are currently working with Electa to make this approach available for all Electa customers in the future.
Got it. We'll go to, there are a few questions that have come in, and then if the panelists have questions for each other, we can go to that as well. There's one question that came in that if we don't have access to MRI in the department, is 3D printing for skin brachy still a realistic process to implement? I'm happy to answer that as well. Maybe Chirag, I'd say we don't routinely use MR for skin. I think that is one of the, I guess, criticisms of doing it is that we do, I guess, standardly use a depth of 3 millimeters, unless we feel like it should be a little bit less or deeper. There is some people do, and we sometimes will use ultrasound to help measure depth. But I think when you don't have that, if it's a relatively superficial lesion, the standard is just to dose to 3 millimeters to be safe. But I don't think that you have to have MR to do that.
Yeah, I completely agree with Dr. Kamrava. I mean, I think routinely we don't need an MRI unless you're going to be doing something that's at much greater depth or something like that. But if you're going to use a traditional applicator or electronic brachytherapy, I don't think an MRI is needed.
You gentlemen are absolutely right, because we have been doing a skin brachytherapy for years and started investigating a possibility of implementation in MRI just in the previous year. So.
Yeah, and then there's kind of a clinical question that relates to using brachytherapy for kind of re-irradiation without getting into the specifics of the case. I would say we do, and obviously Chirag can comment as well, we do consider brachy for retreatment in these settings, but with the same caveats of re-irradiation in any settings. There are higher risks associated, and our main motivation of doing it is just trying to limit the amount of normal tissue overlap, but it certainly doesn't change the potential risks of necrosis or non-healing things. I mean, dose is dose, but it does help you, I think, retreat a smaller area, or at least that's how I view it.
Yeah, I mean, I would agree with Dr. Kamrava. I mean, I think even, someone also treats breast cancer. I unfortunately treat the breast cancer related angiosarcomas, and so we've often given 50 or 60 gray, and I'm now giving another 60 or 70 gray. I think skin demonstrates probably some of the most impressive healing when it comes to re-irradiation as compared to other organs. So I'm not as probably squeamish about re-irradiating skin, but I think what brachytherapy offers you is conformality. I think the only trade-off you have to be careful of is the heterogeneity associated sometimes. And so the question of whether late toxicity from re-irradiation is a volumetric or a heterogeneity hotspot effect, I think is less well defined. So if I do use brachytherapy in the re-irradiation setting, I do my best to limit the hotspots to avoid long-term toxicities.
And then this is a question, I think, for any of the physicists. I guess some vendors have mentioned the possibility of 3D printing in silicone with the idea that it's more flexible and possibly more conformal to complex anatomy. Any if you guys have any comments about maybe just different materials in general than kind of what we've been using, or silicone in particular?
Yeah, so we've actually played a little bit with silicone. For our printer, you have to print a mold that you then pour the silicone mixture into. And you can lay catheters in the silicone before it sets, but you do have to be a little bit clever about how you get those catheters and kind of secure them in the mold to get good spacing. So it's not, for us, we can't print the actual silicone mold and then just, string the catheters through the channels like we can with the blue molds that we showed in our talk. So we've tried it a little bit. We haven't used it clinically, but it could be really nice, for very special cases.
Yeah, and we explored the idea of printing like a silicone mold, a mold for the silicone that you then pour, and you're basically creating a bolus, and then you would have to affix the catheters maybe on top of that. That's maybe a possibility. You're not trying to get the catheters inside the silicone, but we can definitely print molds and pour silicone for some very complex surfaces. And that's something we're exploring both for surface brachytherapy and external beam bolus.
Excellent. Ivan, have you guys played with different materials for applicators, and any comments on your experience with that? Oh, I think you're still muted. I mean, I think we still have you on mute. When we unmute.
Sorry,
Perfect.
sorry
Got
again.
It. Yeah.
So actually, we have a different approach. You have to print out the mold. When you print out the mold, we think that we are done. So, but basically, it's a beneficial. It's a beneficial because once when community figure out how to use the silicone, it will be much easier to conform to the different anatomies. Since we know that there is almost no flat piece of human body, so it has to be with some level of curvature.
And then there's just a question to kind of the CEDARS group in terms of confirming, how do you confirm the catheter has gone completely to the end of the mold before you glue the catheter to the mold? If you guys have a quick comment on that setup.
Yeah, so most of our molds are, the catheter channel path is all the way through. So you can actually, put it all the way through and visualize that it's gone to the end of it. We have had a couple molds where we've had to stop mid-mold, and you can, put a piece of glue on the end of the catheter and put it into the mold until it hits the end. And then since we're bringing the patient back for FIT CT, that catheter has a small radiopaque marker. And so you can visualize that on CT as well.
Yeah, and I think there was maybe once or twice we were a little unsure, and we just threw the mold on the CT table just to confirm before the patient came back also.
Perfect. And then so a question about whether or not there are any practical workshops or hands-on training for these types of 3D printed or handmade kind of molds and applicators. So I'm happy to comment on that. So there has traditionally been a skin kind of hands-on session at the annual ABS meeting. I anticipate that will be happening again, hopefully when we meet in person next year. I believe the meeting's in Denver. So I think that has been the only opportunity that I'm aware of when there's like a real hands-on session. There are hands-on sessions for both prostate, gynae, sometimes breast and skin. So hopefully that will be back up when we're back live again next year. So I think that should be a good opportunity to kind of do that. And then maybe we'll take kind of one more. Let me just look through these as we get. There are some questions about kind of the costs and kind of reimbursements in terms of like the material and in terms of sterilization. So I don't know if anyone wants to tackle that type of question on just briefly before we run out of time. I think you guys are on mute, Tiffany and Jen. Yeah.
Yeah, so what we do bill for a device. So it's a custom device, which is basically the same that you would bill for an Aquaplast mask. I don't know dollar amounts as far as like, is it even profitable? I do feel like when we originally looked at this, it was on par or cheaper than looking at using dot decimal, because when we first looked at 3D printing, we were looking at it for external beam bolus, and it was pretty much on par with what we're spending to order a custom bolus for external beam. So for us, it's been more along the lines of it's expensive in the sense that it takes physicists time to create these. And then as far as reimbursement, I don't know the numbers, but I do know that we submit a complex device for the 3D mold.
It's a great question. I think there are a lot of good things to think about in terms of workflow and costs and reimbursements, but we will have to save that for another time. We're kind of at the end of the hour. Really want to thank all of our speakers for a great presentations. I think it was wonderful to see kind of the wide range of kind of how you can implement these things into your clinic, and there are a lot of different ways of doing it. But it's a really nice tool to have, especially for these curvier places where electrons are really much harder to make work. So thank you again to all of our panelists. There is in the chat a link to, for those who want SACME kind of credit, you can kind of copy and paste that into a browser and go ahead and fill that out. And thank you again for everyone's time.
Thank you.
Thank you.